Dr. S. Jayapriya. I am a junior resident at Fortis Hospital, Cunningham Road. Today I have with me Dr. Mangesh, who is Additional Director and Senior Consultant in the Department of Medical Oncology and Hematology, Fortis Hospital, Cunningham Road. Along with him, we have Dr. Shruthi, who is a Senior Consultant in the same Department of Oncology in Fortis Hospital, Cunningham Road, Bangalore. Today we are going to talk about stomach cancer. So Dr. Mangesh, could you please tell us how does stomach cancer occur, or who is at the risk of getting stomach cancer?
So stomach cancer is one of the most common cancers that we see in our practice. It is also one of the most lethal cancers that we know in our practice. Sometimes you do everything right for stomach cancer may not be cured. And the most unfortunate part is most of the stomach cancers that we see in our practice have some or the other identifiable factor, and lot of those are preventable factors. So let me give a few examples. For example, food. So a lot of people have these so-called processed food, junk food, smoked food, the ones that you see in your barbecue. People think that barbecued food is very healthy, but too much barbecued food and adding a lot of these oils, different kind of oils for barbecue is actually not healthy and not good for the stomach as well. Lot of alcohol is also not good. Smoking or any smoking of tobacco or tobacco chewing, all of these are known to increase the risk of developing stomach cancers. Then there are also certain chemicals that are being used in food nowadays. They are known to have increased risk of stomach cancers. Pickled food, the so-called pickled food, where we add a lot of preservatives to the food and try to preserve the food for long, they can also cause stomach cancer. Food that is not preserved or refrigerated well, food that is not stored well, and then you consume it, they can also increase your risk of developing stomach cancers. There are a few syndromes which can be familially transmitted. We call them hereditary gastric cancers. So there are a few classical mutations that are known to be caused which can lead to stomach cancers. But by and large, if you have 100 patients with stomach cancers, 90 to 95 of them would be caused due to either improper food habits or alcohol or smoking or using too much of preservatives in food.
So Dr. Shruthi, how does a patient with stomach cancer present?
So stomach cancer is a little notorious in the way that it's usually silent in the early stage. But yes, definitely there are a few subtle signs that will indicate probably this is not something simple, it could be a cancer. Especially most of them commonly present with an upper abdominal or epigastric pain. And this is usually, by most patients, it's brushed off as just gastritis. They go to a local doctor, they just get treated for that, take medicines for gastritis. It is relieved and then again it recurs. So then they decide to take their own treatment. They just continue with the same tablets and then they keep neglecting it. So when this pain, usually there is some alteration in this pain. Suppose initially the pain was just present once in a while, but then now suddenly the pain is there continuously. It is there continuously. It is not relieved on medications, or it is relieved for as long as you're taking medications and then it recurs back. These all could be subtle signs which indicate that probably there is some other issue and that needs to be evaluated. And some other signs or symptoms could be that patient is having an early satiety. That is, they eat very little amount but then still they feel full even after eating a little amount, or there might be some loss of appetite itself. They might not feel like eating anything at all. There might be loss of weight, even if sometimes patient is eating well, but still there might be a loss of weight. A significant weight loss could indicate that there is something wrong in the body. So that needs to be evaluated. And very rarely patient can present with a mass or a lump swelling in the abdomen, in the upper abdomen especially, or in very late stages they sometimes present to us with jaundice or complete distension of the abdomen when there is fluid accumulation. Those are all symptoms of later stages, but we want you to know the symptoms that you can detect early. That is mainly that there's alteration in the pain, or pain not relieved even after taking medications for a few days. All these need to be taken care of.
So once a patient comes to you with these symptoms and you suspect that a person has stomach cancer, what are the tests that are carried out?
Yeah, so the first and the most important step would be an upper GI endoscopy. Endoscopy is an OPD procedure where a tube is inserted into the mouth and the stomach mucosa, that is gastric mucosa, is visualized. So the whole of the stomach and the food pipe, everything is visualized. And if there is anything suspicious, any lesion or an ulcer or anything that is seen in the endoscopy, we immediately go ahead and take a biopsy of that just to confirm whether it is a cancer or something else. That is the most important step. Sometimes in very rare cases, we might even have to include an endoscopic ultrasound. Suppose there is something not in the mucosa of the stomach, might be something deep. So we'll need to confirm what it is. So we'll have to do an ultrasound and then go for an FNAC of that lesion. And once this is done, suppose we have done a biopsy of something that is suspicious and that has come out as stomach cancer, then we go ahead and do a imaging, that is a CT scan, which includes the chest, abdomen and pelvis. This will let us know what is the stage of the disease. So that is how much the stomach cancer has spread, whether it is locally, whether it has spread to any of the lymph nodes or to any other distant structures. So these are the most important steps. In very rare cases, we even can go ahead and do a PET CT scan that can give us much more information about the disease spread, and rarely something in the liver that is suspicious, but we do not know whether it is spread from the stomach, then we can even go ahead and do an MRI of it. So these are the most important steps. And also as a part of staging itself, there is something called a staging laparoscopy that is commonly practiced in foreign countries, especially in Japan. Not yet that very commonly practiced in India as a separate procedure, because of course the cost constraints will hold us back. But staging laparoscopy is also a staging procedure to stage the disease, which now in India we combine it along with the definitive treatment. Whatever is the treatment planned, if it's a surgery, we combine it with that. In the initial part itself, we do a laparoscopy, that is put a camera inside the abdomen, visualize the abdomen. This is mainly done because some of the metastasis, that is this disease spread, especially to the peritoneum, they might be very small in the initial stage and they might not be picked up in the CT scan or the PET scan. Might not be 100% picked up. So just to rule out any of this spread, we can go ahead and do a staging laparoscopy and followed by the definitive surgery.
Okay, Dr. Mangesh, once diagnosed and detected, how is stomach cancer treated?
So the same thing that we do for different difficult cancers of the abdomen is what we do in the case of stomach cancer. So once I have the entire diagnosis, so once we have the biopsy report, then we have the staging, that is with the CT scan, PET scan, and sometimes when the surgical oncologist is not sure whether the disease has spread inside the abdomen or not, they may or may not do a diagnostic laparoscopy, and after this the disease is completely categorized and staged. Now after that we meet like this in a multidisciplinary tumor board, and in this case we involve the radiologist and the pathologist. Very, very important. We should not miss our colleagues in radiology and pathology, and we discuss all the aspects of the tumor, and that's extremely important. And the first thing that we always look at is stage. Now we have the diagnosis control stage, whether it's stage 1, 2, 3 or 4. But the benefit of the audience, I will probably categorize it into localized stomach cancer. That means the tumor is localized inside the stomach and there is no extension outside the stomach, and locally advanced stomach cancer, where the tumor is either slightly extending outside the stomach, or there are multiple lymph nodes around the stomach which are involved, and the metastatic or the stage 4 disease, where the disease has spread to either the liver or it has gone to the lungs, or there are multiple lymph nodes even outside the region of the stomach distribution. So these are how we actually categorize these patients. And again, in stomach cancer, it should be understood that if there are 100 stomach cancers being cured, 100 of them have to undergo surgery. Without surgery, it is improbable for us to cure stomach cancer. Am I right, Dr. Shruthi?
Yes.
So you have to somehow work around and make sure that the tumor with the safety margin is completely excised, and details will be given by Dr. Shruthi on that. And my role as a medical oncologist is, again, like I said, coordinate the efforts of the entire oncology team. And if the tumor is pretty large or it's extending outside, we give what is called as neoadjuvant chemotherapy. Now, neoadjuvant chemotherapy basically means that we give chemotherapy before the surgery so that we can reduce the size of the tumor and kill those tumor cells which have escaped outside the stomach and which may in the future spread to the liver or lungs. They are there in the blood streams, so they need to be destroyed, otherwise later, maybe 6 months or 7 months after the surgery, they may cause new lesions in the liver. So that is one more role. And last but not the least, we also have to understand something about stomach. The stomach is one of the organ where blood flow is extremely high. Why? Because whatever we eat has to be absorbed by the blood, and once it's absorbed by the blood, it has to go to the liver. So the blood supply is extremely rich. So it is very high that even if it's stage 1, that the disease is going to spread in the future. So that is the reason why even if it is currently operable, we still have to give some sort of neoadjuvant chemotherapy or a few cycles of therapy before, so that we are first catering to those tumor cells which are spread in the blood. And along with that, if you also get a reduction in the size of the tumor, sone pe suhaga. We are very happy to get that response. My surgeon, Dr. Shruthi, will come and compliment me saying, I'm very happy to do the surgery now and we are going to have a very good result. So that is the idea of giving neoadjuvant therapy. And once the surgery is done, the details of which she will give, we also have to consolidate with what is called as adjuvant therapy. Now why again? Again, like I said, when she is operating, there is going to be a lot of blood that is going to be flowing around, and there is a lot of surgical time that is there, due to which there is possibility of leakage of the tumor cells into the blood circulation. So after the successful surgery, 3 to 4 weeks after surgery, I come into the picture and we will give adjuvant chemotherapy to make sure that the surgical area wherever some tumor cells have been left behind are also destroyed, and those tumor cells which could have leaked into the blood will also get destroyed. And nowadays, in the latest last 2 years, we are also employing immunotherapy for those elderly patients who may not be desirous of undergoing further chemotherapy. So we give some sort of immunotherapy so that the tumor can be controlled and the body's immunity can be activated and the tumor can be destroyed by the body's immunity. There are a few situations that we kind of modify the therapy depending on the age of the patient. For example, the patient's age is too much, we can't give the standard intensity of chemotherapy, we reduce the intensity of chemotherapy. Sometimes we also use immunotherapy or targeted therapy to reduce the size of the tumor so that the best surgery can be done. So in essence, our role is what is called as to provide the two breads of a sandwich, where the inner part of the sandwich is the surgery and the two breads are basically the neoadjuvant and the adjuvant chemotherapy. Now it is also important for us to know that if I give neoadjuvant therapy for a patient and the tumor responds well, for example the tumor size is 5 centimeter or 4 centimeters, the tumor responds and comes to 1 centimeter, the curability of this patient is much higher than another patient whose tumor size remains the same or even unfortunately increases while we are giving neoadjuvant therapy. So that can help us to actually tell the patient confidently that your chances of cure is very high if the tumor has responded really well.
So coming to the surgery part, as Dr. Mangesh already mentioned, surgery is definitely required if you're looking at cure for stomach cancer, and this can be performed easily in case of early gastric cancer or, as he told, localized gastric cancer. And when it comes to surgery, we mainly what is the surgery done is removal of the stomach. But in very few cases where there is an early tumor, that is a very small tumor in very highly selected patients where it is involving only the mucosa, not yet gone into the muscle layer of the stomach, we still have the option of endoscopic resection. That is not commonly done in our country because we do not see such early tumors, and it's commonly practiced in those countries where they have a regular screening program where where the patients undergo upper GI endoscopy every once in 2 years, so they are able to detect these early lesions. But in case someone is undergoing an endoscopy for some other reason, probably like gastritis or something else, and such early lesions are detected, we can definitely go ahead and do an endoscopic resection if the CT scan and other staging modalities do not show any spread of the disease. And the main intention of treatment here is that is the surgery here is to remove the tumor along with an adequate margin. We have something called a 5 centimeter of margin in stomach which we look into. If we are able to remove with an adequate margin, then we can go ahead even with a partial removal of the stomach, and along with clearance of the lymph nodes, that is the draining lymph nodes of the stomach. That again will depend on the location of the tumor. All those lymph nodes need to be cleared to give a proper cure for the stomach cancer. And coming to the ways in which we can do this surgery, it can be either done by an open surgery or by minimally invasive techniques. Minimally invasive technique would involve either a laparoscopy or even now a robotic surgery. And oncological outcomes, if you look at it, both open surgery or minimally invasive surgery have equal oncological outcomes in stomach cancer. But the main advantage of laparoscopy or robotic would be that it will be a minimally invasive procedure, so there are smaller incisions, pain is going to be less, recovery is going to be faster, so hospital stay is also going to be lesser.
Dr. Mangesh, is stomach cancer curable?
Yeah, that's a good question. So, stomach cancer is definitely curable, but the stage matters, the treatment matters, and how well the treatment is given also matters. So, just to give a very simple picture, in high volume countries where stomach cancer is very common, like Korea, Japan, they have a lot of experience about stomach cancers, and they have published probably the maximum number of papers, both in medical part of management of stomach cancer as well as surgical part of stomach cancers. So they have said that if the cancer is detected in stage 1, around 90 to 80% of the patients can be cured. Those who have stage 2 and stage 3, probably 50 to 35%. So out of 10 patients, maybe 5 will be cured, or if it's stage 3, maybe even only 3 will be cured. And this is despite a successful surgery, the best of chemotherapy and whatever you do. So that means that it is difficult to get rid of all the tumor cells, due to which some of the cancer seems to spread or come back. Stage 4, very difficult, 5 to 10%, and that too if the patient is taking immunotherapy, the latest of targeted therapy, and so on and so forth. So it is a very difficult cancer to be cured despite our best efforts, and that is the reason we highly recommend that you do not let go of these long-term symptoms that you have of stomach cancer, such as bloating, indigestion, gastritis. In our country, it is very common for patients to go endlessly to the medical shop to get gastric tablets. That is very bad, and we see a lot of times patients who have very low hemoglobin, anemia, right? So there's one patient we had last week at our OPD. Patient has just anemia, evaluated here and there. They found that in the stool they found traces of blood, and when we evaluated the patient by an endoscopy, patient had tumor. But this particular patient was taking generic treatment for last 6 months. Unfortunately, after all the evaluation, we found that the patient has stage 4 cancer. This patient did not have any abdominal pain, no weight loss, just anemia. Hemoglobin was low, that's all. And this is how stomach cancer can present, and the word that Dr. Shruthi used was, it is a silent cancer. It is very difficult for us to identify a lot of these silent cancers in the early stage.
Dr. Shruthi, are there any screening tests for stomach cancer, and are there any preventative measures one can take?
Yes, definitely both I'll talk about. First, talking about the preventative measures. As Dr. Mangesh already mentioned, the risk factors for stomach cancer, one could be the diet. So obviously changing your diet, which includes a low salt diet, not using much of smoked food or canned food or processed food, these all can decrease the risk of stomach cancer. Along with that, including more of fruits and vegetables and fiber-rich diet can decrease the chance of stomach cancer. And then avoiding smoking, alcohol, all those risk factors. And one common risk factor is H. pylori infection, that is Helicobacter pylori, which is a bacterium. This infection is commonly prevalent in our country because of the poor sanitation and the hygiene and all that. So this definitely can be treated. There are antibiotics which are available to treat this infection. It's a simple infection. So any patient who is having repeated gastritis or pain abdomen can undergo an endoscopy, and if H. pylori is detected, and taking treatment for that will definitely reduce the risk of stomach cancer. And again, maintaining weight, like for any other cancer, maintaining healthy weight, staying healthy, staying active will all help in decreasing the risk of stomach cancer. Now coming to the screening tests available, yes, upper GI endoscopy is the most important screening test for stomach cancer. Not commonly done in our country, not commonly practiced, because obviously patients are a little scared about having an upper GI endoscopy done. And this is just an OPD procedure. It is not something that needs to be scared about. It's a simple procedure. There's not much of a discomfort. We have so much of medicines that are now available which can make the procedure easy and simple for you. And especially if you have a family history of stomach cancers, anyone in your family, a relative or someone who has stomach cancer, then it is good practice to undergo screening regularly. Usually prefer to start at least at the age of 40 years, or at least what we prescribe is 10 years before the previous relative who was detected, at least 10 years before that. And as Dr. Mangesh mentioned, some of the genetic conditions like hereditary diffuse gastric cancer, if there is a genetic condition in your family, then this upper GI endoscopy should be started even as early as 25 years of age. This endoscopy can be done, doesn't have to be done every month. It can be just done once in a year or once in 2 years, depending on your risk. That of course we can discuss with you regarding how much of at risk you are, and depending on that, then we can based on that we can formulate the screening guidelines for you. But this simple test can be done. If you are scared about upper GI endoscopy, then there is another test called barium test, which also can be done for detection of stomach cancer. It might not be as sensitive as an upper GI endoscopy, but if you're really scared and you are at high risk with a family history or a hereditary, if you are at high risk, you can definitely go ahead and get the barium test done.